Hi everyone, my name is Anuj Ohri, and along with Rishi Mehta, we are the lead hospitalist for the Keck Hospital inpatient COVID-19 teams, and we are here today to talk about COVID-19 risk factors and prognosis. As you may remember from the first grand rounds, the majority of COVID-19 cases are non-severe, comprising about 70 to 80% of the total cases. 15 to 25% of the cases are classified as severe, and 5% are classified as critical. Now, we will be spending most of today's talk focusing on the severe and critical cases, as these are the patients that likely require hospitalization and ICU level care. First, quickly to touch on mortality for these patients. Now, by and large, the cause of death for COVID patients ends up being respiratory failure at about 53% of cases. 33% of cases are due to a combination of respiratory and circulatory failure, and a small percentage of cases are due to isolated circulatory failure alone. Now, as we're learning more about COVID, we are recognizing there's other pathophysiologies that contribute to their mortality, and also are a large source of morbidity for our patients who are hospitalized in the ICU. The most commonly known complication for COVID is hypoxemic respiratory failure and subsequent ARDS. This can be so severe as to require sometimes the use of ECMO, and ARDS is seen in about 67% of hospitalized patients and 100% of patients who require mechanical ventilation. These patients also have a prolonged intubation time, with the median time to extubation being about 11 to 17 days. A recent phenomenon of a cytokine storm syndrome has been identified in these patients, which is basically a hyperinflammatory syndrome characterized by fulminant and fatal cytokine release in certain cases. This usually results in multi-organ failure, contributing to both their cardiac dysfunction, their renal dysfunction, and their respiratory dysfunction. This can be seen in 3 to 4.3% of cases. Another complication, owing actually to the incidence of circulatory failure in these patients, is direct cardiac injury and fulminant myocarditis. This can result in a pretty severe cardiomyopathy for these patients, and in one center's experience in the ICU, having at least 33% of patients who end up having evidence of cardiomyopathy. This can occur through a few proposed mechanisms, one potentially being the cytokine storm, and the second potentially being direct viral infection of the myocytes using the same ACE2 receptors that are overexpressed within the lungs and in the heart. A variety of neurological symptoms ranging from agitation to delirium, to changes in the reflexes, to muscle weakness, to even executive dysfunction has been identified in some of these patients. In one study, it occurred in up to 84% of patients who were actually within their ICU. A fairly recently identified complication that we're starting to see more and more is an increase in venous thromboembolism. Now, in a single study, they identified 25% of patients who actually had a DVT and were admitted to their ICU. And possibly as a result of the cytokine storm, COVID-19 patients also have an increased incidence of acute renal failure and the need for renal replacement therapy. The estimates for renal replacement therapy range from 1 to 5% of hospitalized patients, but among the critically ill, the need for CRRT actually ranges from 5 to 23%. In looking at our data for patients who are admitted to the ICU, we see that in some of the earlier ICU studies, particularly the ones that came out of Wuhan, China, patients had quite a high mortality rate, and that often when patients required invasive ventilation, their mortality rate was quite profound. This was reaffirmed in some of the earlier studies that we've seen in the ICU in the United States, with the Evergreen ICU study showing about a mortality rate of 67%, a Seattle multi-center ICU study that showed a 50% mortality rate, and then a large cohort of patients, which is nationally reported in the UK, of about 2,936 patients, having a 51.1% mortality rate. So what does this evidence tell us in terms of how we can predict who will have a poor prognosis when they become hospitalized? Now, as presented in part 1 of Grand Rounds, we know from a Lancet study that was published fairly early on and looked at Chinese data out of Wuhan, China, that older patients had an increased risk for severity. We also know from a recent review that age and comorbidities are important predictors of severities, but it bears repeating that this review article found that age greater than 65 and coronary artery disease, more so than hypertension and diabetes, seem to be independent prognostic factors for death. Another systematic review and meta-analysis confirmed not only elderly age as a risk factor for critical illness, but also identified the male gender as potentially having a risk factor for more critical disease. As US data gets published, we see that it confirms existing literature as it pertains to age. The CDC data on severity shows that while hospitalizations occur most significantly between the ages of 20 to 74, ICU admissions and death occurs greatest at ages greater than 65. And as more US data comes out, as discussed in part 1 of Grand Rounds, we see that obesity is a common underlying condition for hospitalized patients. In fact, obesity is the second most common underlying condition, only secondary to hypertension. More recently, we have new evidence to suggest that obesity is not only a risk factor for hospitalization, but a prognostic indicator as well. 2 studies have recently come out highlighting obesity. In a French retrospective cohort study looking at 124 ICU level patients, the authors showed a high frequency of obesity among patients admitted in the ICU. In fact, disease severity increased with BMI, and the need for mechanical ventilation was associated with BMI independent of age and comorbidities. In a recent New York study, researchers looked at 3,000 patients who presented with COVID-19 and found that BMI was an independent risk factor for ICU admission. In fact, it showed that even when under the age of 60, if a patient was obese, they were more likely to be admitted to the ICU. Now, specifically in those under the age of 60, when compared to BMI less than 30, those with a BMI of 30 to 34 were 1.8 times more likely to need ICU, and those with a BMI greater than 35 were 3.6 times more likely to need ICU level care. Putting patient characteristics aside, what lab markers can we look at to predict decompensation and severity? Much has been said about ferritin and LDH as important markers, and the literature suggests that they are elevated in severe cases. But there are other confounding factors for elevated ferritin, and for both LDH and ferritin, their trend does not always correlate with disease progression. This is in contrast to D-dimer, which a Lancet study recently had shown that D-dimer greater than 1,000 on admission actually predicts severity for the patient. A more recent study showed that D-dimer greater than 2,000 on admission actually was a predictor for hospital mortality. Lymphopenia is another predictor of disease severity. One paper in Nature showed how lymphopenia on admission predicted poor outcome and also trended with disease severity. Here we see that the severe cases that eventually were cured and those with severe cases but eventually died started with very similar levels of lymphopenia at admission. But as the disease progressed, the lymphopenia did diverge based on whether the patient died or survived. This compares to those with moderate disease but eventually got cured that started and ended at different levels of lymphopenia and much higher levels of lymphopenia. Now, clinically, having a lymphocyte count of less than 1.1 was associated with a 3 to 5 times increased risk of death. Finally, the most talked about lab marker is CRP. One recent study showed not only does an initially high CRP predict severity, but as the disease progressed, the CRP correlated with progression. And a study in New York that focused on clinical decision-making found that a CRP greater than 200 on presentation correlated with critical illness and an approximate 5-fold increased risk of developing ARDS. As hospitalists, we can use the information about risk factors to help stratify our patients coming into the hospital and prioritize the need for advanced care planning discussions. Practically, this means identifying the patient's code status, goals of care, and surrogate decision makers early in the hospitalization and before a potential decompensation. In addition, we have been trying to reach out to PCPs and skilled nursing facilities to encourage a dialogue to either begin or clarify the patient's wishes and their goals of care. And certainly, we have a very low threshold for early involvement of our palliative care colleagues to assist in a more nuanced discussion with the patient and their family regarding their goals of care and their code status. Thank you. And with that, here are our references, and I thank you very much for your time.
Welcome everyone. I'm Carin Van Zyl, and I'm the section head of Palliative Medicine on the county side. I'll be talking today about COVID-19, its unique impacts on the safety net population, and how the most vulnerable of this group, those with life-threatening illnesses, are having their access to palliative care affected. This is meant to be only a brief overview given the amount of time that we have. In the next 15 minutes, I will summarize some of the unique burdens the pandemic has imposed on the homeless, incarcerated, nursing home, and undocumented populations. Although so much good work is ongoing, I can highlight only some of these high-impact efforts underway to protect these groups. Many of you are involved in these efforts, and I ask forgiveness if I'm not able to mention all of your work. Lastly, we will talk about how the experience of those dying of COVID and other illnesses have differed, and how the quality of that experience has been affected by the pandemic. Now let's talk about the homeless population. California's is the largest in the country, with over 150,000 unsheltered persons statewide, and somewhere between 36,000 and 44,000 in LA alone. As of last weekend, 33 people had tested positive, although this is almost certainly an underestimation given the testing issues that we've all experienced. Both on the streets and in the shelters, there's been inevitable close contact with soap and water, bathrooms and laundry in really short supply. There have already been outbreaks in shelters. The largest one was in San Francisco, with over 100 affected patients and staff. In Los Angeles, there's been one at the Union Mission, and unfortunately, even the death of a staff member. It's been really difficult to test, track, and logistically support those who have been isolated, but this has not been for lack of trying. There's been a robust public and private partnership trying to get the homeless off the streets and into shelter to better do this work. Project Roomkey was announced last week, where over 16,000 empty hotel rooms have been repurposed, with 4,200 placed by last weekend. Our own street medicine team is planning more rapid turnaround testing to deliver more masks, hygiene supplies, and tents, and to do more education on social distancing. All of these efforts are focused on keeping older and higher risk patients out of the hospital where they're safer. This requires more medical support once housed. The Illumination Foundation is one of many organizations that has long been involved in medically supportive housing and continues to work with the city to provide more. Let's move on to the impact felt within the incarcerated population. It's been well publicized for years that both prisons and jails have been overcrowded. It's not just the cells that are too full and is set up for an outbreak. Courtrooms, exercise yards, and holding cells have all been dangerously overcrowded. The Bureau of Prisons data show that as of 4/20, close to 500 inmates have tested positive, almost as many staff, and there have been 22 inmate deaths nationwide. In LA County, the jails as of 4/20 had almost 2,000 people in quarantine, 26 inmates testing positive, and 64 in isolation. Lastly, correctional facilities have not been prioritized for PPE and have had staff shortages as employees have fallen ill, further compromising the safety of inmates and staff. Within the correction system, the response's emphasis has been on decarceration, reducing arrests and speeding early releases for those who are eligible to reduce crowding. This has sometimes been spurred by class action suits. As you can see, LA jails have already reduced their prison population, and I understand that there are efforts to reduce this even further. According to the Sheriff's Office, this has been accompanied by less violent crime, with the exception of a sharp increase in domestic violence incidents during the lockdown. There have been attempts to physically distance inmates with cots, tents and exercise yards, and temporary bathrooms with more access to hand washing, but these efforts have met with uneven success across jurisdictions. There is also dedicated isolation housing for those who've been exposed and need quarantine. There's also aggressive testing taking place of all incoming personnel and inmates. Visits with legal counsel are now remote for the most part, and visitors and outreach programs have been suspended. In the nursing homes, there's another ready-made fragile population where a pandemic can wreak havoc. However, the workers there are also vulnerable. They tend to be low-wage earners, they're considered essential and can't stay home. They're mostly women who are sometimes undocumented, and they're often without enough PPE, like many of us in the healthcare field. The California Department of Public Health recently released information on almost 300 SNFs around the state and revealed that more than 3,000 positive cases were among the patients and staff. There have been accelerated efforts by doctors to determine who among their poor prognosis patients in nursing homes would want to actually avoid aggressive care if they were ever infected. But unfortunately, many of these conversations have not been held in time. More discussions are now being held in high-pressure environments like the ER when the patient's already distressed and infected. In general, it's really hard to have a considered and thoughtful conversation that truly reflects the real values of a patient who feels like they're drowning when you're holding what looks like a life preserver. Anecdotally, I'm also hearing from colleagues around the country that in the chaos of trying to transfer a really sick nursing home resident quickly to the acute care setting, their advance directives and pulse aren't always following in the transfer paperwork. We've all heard of several cases of patients who didn't want this level of care, but received it anyway. The undocumented patient population has been hit extraordinarily hard. They're often performing low-wage but essential functions with limited ability to distance or stay at home. By one estimate, there's over 250,000 undocumented workers in healthcare alone. On the other side, these populations often carry disproportionate prevalence of medical factors that portend poor prognosis outcomes in COVID infections. And indeed, there are some distressing data coming out of New York that shows disproportionate death rates in Black and Hispanic residents. Unfortunately, it appears that ever-present healthcare disparities are also playing a role. We're getting indications that some pursuing legal immigration fear coming in for COVID testing and care because they believe that they will be penalized by the public charge rule, which says that any reliance on a public service will count against someone in an immigration proceeding. This is despite the fact that COVID testing and care is actually exempted. Asylum seekers who've been kept in detention in unimaginable conditions near the border have also been unable to socially distance adequately and are kept without adequate access to sanitation. Some of them are reporting being exposed to symptomatic ICE employees. ICE has reported at least 220 detainees who are positive. The response in California has been a little more progressive than in other parts of the country. Here, California is committed to assisting undocumented workers who are not covered by the recently passed CARES financial aid package. California is developing a $125 million fund in partnership with grant makers concerned for immigrants and refugees. They're rolling out a system where there is a $500 per adult payment, a $1,000 per household cap for those who have been affected financially by the pandemic. Under the threat of multiple lawsuits, ICE has been reviewing cases of detainees who are considered high medical risk and slowly releasing some. The pandemic has introduced a number of difficulties in providing hospice and palliative care to some of the most vulnerable of the already vulnerable, and this has made an already difficult time much harder. Again, this could be a much larger talk by itself, so I'm only able to mention the most visible impacts. My hope is that my colleague Dr. Puri might be able to talk about this in more detail. Our experience at the county has been divided among two groups, COVID patients and non-COVID patients. What I can tell you is that the patients that we're seeing with COVID are not surviving de-escalation of care for very long, and certainly not to discharge. So they're escaping many of the practical hurdles we're starting to see in the provision of palliative care or hospice more downstream. The major change we're experiencing in the care of COVID patients is that we're not able to compassionately extubate those dying on the ventilator because of the risk to staff. Instead, we're de-escalating to minimal vent settings. Of those who are dying of other conditions, the new complications are more long-lasting and are cropping up further downstream. Telehealth, for instance, diminishes our ability to do a lot of the psychosocial support, which relies on face-to-face rapport building. Visitor restrictions and prohibitions have been very stressful for patients and staff and have affected goals of care discussions. It has certainly affected families getting closure in the deaths of their loved ones. All of you have heard about the heartbreaking instances in which patients dying of COVID are doing so alone and without access to their loved ones who just want to say goodbye. Some of the off-the-ground, innovative hospice programs that had just been started prior to the pandemic are now on hold, so that those resources can be devoted to other projects supporting the homeless. Everyone's having trouble placing SNF patients, but our hospice patients are unusually reliant on this mechanism to get hospice care, and we're finding that more often they're dying in the over-medicalized environment of the hospital. We're definitely seeing more mental health, financial, and housing instability, which affects patients' ability to go home on hospice, and their already stressed caregivers taking on an additional burden. I'm also hearing from colleagues from various parts of the state that they're more often caring for inmates who are dying still in shackles. It's important to know that inmates dying in shackles is allowable per policy, but more often than not, we're able to secure from the watch commander the last few hours or days free of any bonds to a hospital bed. Because of staffing shortages, some of these requests are not getting granted as often or in time. This has led to some serious moral distress on the part of the people who care for dying inmates, and it's certainly affected their families. We think for the same reason, there has been some uneven responses to compassionate release requests, and this is despite the pressure to quickly decarcerate. We've also heard from some of our hospices that they have had their PPE shipments confiscated, which compromises their ability to take on more hospice patients. Despite all of this, because of the tireless work of advocates in the safety net and our partners in other services and in hospice and home-based palliative care, all of these affected groups are still able to get palliative care. It's harder, but it's not impossible. If you'd like to get involved with any of the safety net population or a group that's working to fight for them, I've mentioned here just 3 of the organizations that are working to fight for these folk. These particular organizations have specific connections to the Trojan community. In closing, our most vulnerable populations are definitely being affected by COVID, and their limited ability to respond is being stretched. Despite that, though, there are really heartwarming and coordinated responses, both privately and publicly. There's no doubt that much more work needs to happen, but I will say that it's restored my faith in humanity to see people trying so hard. The most stressed in these groups, those who have serious illness or are succumbing to serious illness, can still get what they need, even if it's not ideal. So if you have a patient that you think needs palliative care, please ask us how we can help. Thank you so much for your time and attention.
Hi, everybody. It's good to be with you today. My name is Sunita Puri, and I work on the Palliative Medicine Service and on the Ethics Resource Committee over at Keck and Norris. And I'm happy to be speaking with you today about managing suffering during a pandemic, the roles of medical ethics and palliative medicine. What I hope to do in our time together is to describe the ethical basis for the concept of resource allocation in the setting of this pandemic. I'll also give you an overview of the policy we've written at Keck and Norris for resource allocation should our supply of things such as ICU beds and ventilators be less than the demand for them by sick patients. When I turn to the portion on palliative medicine, I'd like to share with you the different roles that palliative medicine plays in supporting patients, families, and care providers in this time, and how it's actually not very distinct from the role we've always played. And hopefully we will have time for some questions and answers. Before we get into the specifics of modern day resource allocation in the setting of COVID, I'd like to give you a little bit of historical context around the concept of triage, which is interchanged with the concept of resource allocation. So the origins of the word triage are actually French, trier, which means to sort or to separate out. And the origins of that word are approximately around 1792 by a Baron Dominique Jean Léry, who was a surgeon-in-chief in Napoleon's Imperial Guard. So the concept of triage is old, and it is also originating really in the setting of combat on a battlefield. There's a beautiful essay by Dr. John Kerstetter, who himself is a doctor and a soldier who served 3 tours in Iraq, and he wrote an essay called Triage, in which he wrote, based on his experience on the battlefield, if the triage officer calculates that a patient falls into the expectant category, treatment is withheld in order to allow medical teams to concentrate more efficiently on those soldiers with potentially survivable injuries. Preserving the fighting force is the central tenet of the process. And so this is what he's written about is one of the reasons why triage and resource allocation can make us feel so uncomfortable is that we're making decisions about who has immediate access to a treatment and who does not based on a specific outcome. And on the battlefield, that might be preserving the fighting force. And in the context of COVID, as I'll get into in more detail, the whole principle of resource allocation is really advancing the goal of helping the greatest number of people to survive to hospital discharge. But translating the concept of triage in a battlefield context into a non-battlefield context makes many of us uncomfortable. So one of the key things to note about the shifts in ethical practice in the setting of resource allocation is that we're really moving from patient-centered ethics, which is how we've all been trained, to the concept of population-centered ethics. What that means is that while we are generally practicing in the mode of seeing the patient before us and providing medical care that is in the best interest of that specific patient, when we move to population-centered ethics, we are really trying to use resources to enable the most number of people to survive to hospital discharge. And that sometimes means that the needs of the particular patient in front of us cannot be met as they would be met if we had more abundant resources. At Keck and Norris, we would only start to categorize patients in terms of their priority access to a scarce resource if we were at 15% or less of the specific scarce resource, and also if a public health emergency has been declared. So the use of resource allocation or triage only is done in very, very specific circumstances. And when I use the term scarce resource, while many of us might think of just ventilators and ICU beds, what we've defined as a scarce resource goes beyond that. It could include CRRT machines, intra-aortic balloon pumps, pressors, sedatives, and paralytics, some of which have become in short supply in various parts of California and the country, and even medical and nursing staff availability. So if many staff themselves were sick, or if they had been exposed to a patient with COVID and have to be at home on quarantine, understandably, just the workforce itself could not be in the necessary supply to care for the patients in need. So scarce resource is really an elastic term that goes beyond vents and ICU beds. As I mentioned, the goal of using scarce resources in a specific way would be to help the greatest number of people survive to hospital discharge. But that, when we're in triage mode, that does not mean we abandon really core ethical concepts of medical practice, including a duty to care, a duty to steward scarce resources, a duty to really adhere to the concepts of distributive and procedural justice, and our duty to be transparent with patients, families, and each other about what it means to be in resource allocation mode and how that impacts everybody involved. As I'll detail in the coming slides, we prioritize patients based on very specific criteria. And I want to acknowledge that this is, as I said earlier, a departure from how we are trained, and as such, being in the mode of resource allocation can be a source of significant distress. The steps in resource allocation include, number one, being informed that we are at 15% or less of scarce resources available. And when that is the case, the hospital administration will alert the medical center and staff that we are in the mode of resource allocation. The prioritization of patients will not be done by the frontline physicians caring for the patient. They will be done instead by the triage committee, which is comprised at Keck and Norris of a team of clinical volunteers, mostly in the areas of critical care, surgery, nephrology, cardiology, hospitalist medicine, palliative care, and ethics, along with nurses and social workers. And this is a medical staff committee. There's also a separate committee called the Triage Appeals Committee, which is comprised of a completely different membership than the Triage Committee. And the Appeals Committee would hear any appeals from patients, families, or even other staff regarding decisions made by the Triage Committee. We use the SOFA score, and we also use a comorbidity or prognosis score that numerically captures, to the best of our ability, the patient's prognosis due to their comorbidities at baseline before they got sick and needed access to a scarce resource. And there is an ongoing reassessment of patient status. So we are constantly in touch with the ICU teams when we are in triage mode to make sure that we are determining who is getting better and may need to come off of a ventilator and allow somebody else to get on it, and who may not be doing so well and may need to be taken off of life-sustaining treatment. Many of us are familiar with the SOFA score, the Sequential Organ Failure Assessment Score. And as you'll see here, we assign a numerical value to different physiologic markers that the patient comes in with at baseline at the time of admission. Once we've calculated the total SOFA score, we then assign a certain number of points from 1 to 4 to numerically capture the mortality associated with specific SOFA scores. So for example, if you have a SOFA of less than or equal to 6, you would get 1 point assigned. If you have a SOFA greater than or equal to 13, you would have 4 points assigned, and so forth. The next scoring system relates to comorbidities and prognosis of the patient. So before they come into the hospital, if they have no significant comorbidities, so let's say they're 25, fairly healthy, no other medical problems, they would get 0 points added to their SOFA score tally. If they had some major comorbid condition that would substantially impact long-term survival, they'd get 2 points. And if they have a severely life-limiting illness that would make them likely to die within a year, then we would give them 4 points. To go through the major comorbidities, so these are people with an approximately 5-year survival. This is the list of suggested criteria. So malignancy with expected 5-year or less survival, moderately severe chronic lung disease, chronic heart failure, chronic liver disease, end-stage renal disease in patients with few additional comorbidities and no other organ system failure, and progressive neurologic disease, but with the ability to perform some ADLs and you're not completely bedbound, and moderate Alzheimer's disease or related dementia, again, with the ability retained to do some ADLs, but still and not be completely bedbound. The severely life-limiting comorbidities, there's actually quite a lengthy detailed list in the actual policy. To summarize a bit here, these are some of the issues that might lead to a prognosis of less than a year. Metastatic cancer with no further treatment options and other associated issues such as refractory or recurrent PEs, severe malnutrition, malignant spinal cord compression, and others. Liquid tumors with refractory cytopenias and no further treatment options, or patients with GVHD grade 3 or 4. Chronic heart failure with an EF of less than 20% despite max therapy, recurrent cardiac arrests, or patients with significant symptoms such as dyspnea despite max therapy that really severely limit their functional status. End-stage COPD, ILD, or other chronic lung conditions, end-stage liver disease without a transplant candidacy, and progressive neurologic diseases, including dementia, where patients are really bedbound, dependent on others for all ADLs, and or using BiPAP if in the instance of things like ALS. And end-stage renal disease with multiple irreversible comorbidities. Again, there's a lengthier, more detailed list in the policy itself. This is just a summary, but I'm happy to send you the full policy if you're interested so you can take a look at the full detailed list of severely life-limiting comorbidities. So we take the score from the SOFA and the score from comorbidities, and we total that score in order to give people a priority grouping. Patients with a priority score of 1 to 3 have a priority grouping of green. And that means kind of like green light, they're a go to get access to the scarce resource. If you have a priority score of 4 to 5, then you're in the yellow category, which means you're kind of intermediate priority for access to a scarce resource. And if somebody in the green category comes off of the scarce resource, then you would be up next. And if you're in the red category, you generally have a priority score of 6 to 8, and you're so sick that at that time you are not the highest priority for access to the scarce resource. Patients in the blue category are those for whom critical care is not necessary. And I want to emphasize here that even though people in the green group would be first priority for access to a resource, we still provide the very best medical and supportive care to patients in the yellow and red group. So it's not a binary of either you get the resource or you don't. It's on a continuum really, where you may be given the best care possible, and hopefully that sustains you to get to the scarce resource. As I mentioned, we are often reassessing these patients. So in resource allocation mode, we have formal 48 and 120-hour reassessments using SOFA scores and taking the input of the attendings taking care of the patient. We keep a log of all patients who are needing access to resources, and on a daily basis, we're touching base with the teams to determine whether somebody in a certain priority grouping needs to be moved up or down. We do not consider age as part of a priority access issue. So at some institutions, if, for example, 2 people have the same score and would be up next to a scarce resource, they use age as a tiebreaker, and we don't consider age in our policy. The reason being that at Keck and Norris, we actually see a population of fairly young people with complex medical issues. So it's not unusual for us on our service to see a patient in their 20s or 30s with a widely metastatic cancer and also to see a 65-year-old who may not have had major medical issues in the past. So age doesn't accurately capture survivability, which is again our main outcome here. We do give priority to frontline healthcare workers and first responders to get access to a resource, assuming that they, if they get access to the resource, have a fairly good degree of survivability and the ability to return to work. As I mentioned earlier, there's really no binary going on here between getting a resource or not getting a resource and not being cared for. And the reason I mention this is that patients and families are reading what's coming out in the press. And there have definitely been headlines and content and articles which aren't exactly capturing the reality of how triage works. Some of those headlines might be, doctors are deciding who lives and who dies. And while that's a great catchy headline, it doesn't capture what happens in resource allocation mode, which is that we don't either put you in the ICU or discard you and let you die. It's that we give priority access while still providing the very best medical and supportive care to all comers. So just recognizing that some of the information out there, what patients and families are taking in, they may need a little bit of extra reassurance that what those headlines say are not true. To return to Dr. Kerstetter's essay, in triage mode, saving lives is the end point of all triage. Let one life go, save 3 others or 5 or maybe 10. The ratios don't matter, the benefits do. And a benefit in war always comes at a cost. So I want to get into some of the costs that we may see, not on a literal battlefield, but in what can often feel like a war against an invisible, menacing virus that has caused true devastation in our country and world. One of the things we're already observing is that the coronavirus has kind of brought to light and exacerbated existing health inequalities. So what that means is that patients who are vulnerable and marginalized historically have been getting infected at a greater rate. And these are people who may not have had the best access to healthcare in the past for reasons of access or mistrust, among other things. And so we're seeing that this crisis is exacerbating what we already know to be true. And so some of our priority groupings, for example, make use of a comorbidity score. And many patients who fall into these categories where they have not gotten equal access for many reasons or have not engaged in the medical system historically, their priority score may be higher than somebody who has had access for their whole life. And what that means is that people who have long suffered health disparities may not be as likely to get access to scarce resources. So this is an imperfection in our priority grouping system, but it is very much a reality that we all need to be aware of and sensitive to. There's definitely discomfort over what the endpoint of triage means. And while on a battlefield, it may make sense for us to try to save soldiers' lives so they can go back to being soldiers, it doesn't translate as well in a non-battlefield situation. So we may enable someone to survive, but their quality of life may not be what many of us would hope a patient's quality of life would be. So the endpoint we're going for in triage mode is certainly a challenge to get used to. Moral distress over the concept of triage and fear of lawsuit is a very, very real thing, as is the difficulty of communicating the concept of resource scarcity and what that means for decision-making for patients and families. There can be disagreements on prognosis between the triage team prioritizing patients and their patient subspecialists. And it's very difficult if we were in a true surge situation to make these really weighty decisions under time pressure. And also supporting patients, families, and staff through the grief and powerlessness and hopelessness that this particular situation has brought about is a real challenge we see now and will almost certainly continue to see if this crisis gets more intense. I want to shift on that note to the concept of palliative medicine in a pandemic. And because I'm somewhat obsessed with etymology, I'd like to take it back to the origins of the word suffering, which is really the concept that palliative medicine seeks to address at all times, but particularly amidst the new forms of anguish and suffering that we see in this crisis. So some of the earliest documented terms associated or that mean suffering come from Sanskrit and Pali, which is the Buddhist script. And the concept of dukkha or dukh that was a term that really encompassed the many shades of suffering that include resistance to what is, among other things. The concept of suffering in the Anglo-French origins of the word souffrir include the idea of bearing and enduring something troublesome or unwanted. And in palliative medicine, we really try to understand the different shades of suffering that somebody may be experiencing, and we use an interdisciplinary approach to address the multidimensional forms of suffering that patients and families experience, including physical pain, emotional and spiritual pain, and existential distress. In the setting of a pandemic, our work becomes even more important because we are suddenly dealing with something that has a fairly high mortality and morbidity. We're helping patients and families and staff deal with the extreme uncertainty that this outbreak has caused on our lives. And there's this idea that people are vulnerable no matter what their age and health status. So the idea, as Joan Didion wrote in The Year of Magical Thinking, the concept that, quote, life changes in the instant, the ordinary instant, applies more now than ever. And it brings to bear a kind of new set of suffering and grief that's layered upon what we've seen before. The unique forms of isolation, such as our restricted visitor policy and social distancing, also make it hard for patients to endure being in the hospital and for families to really get the sort of communication and involvement with their loved ones' care that they might previously have been able to do. So we help with advanced communication around goals of care and symptomatic support. And just a note that palliative medicine is a distinct practice from the ethics-based practice of resource allocation. And I mention that because there's a misconception that palliative medicine participates in deciding who gets access to what. And we've previously been identified and associated with quote unquote death panels, which we all know is ridiculous. So just to say again, we are not involved in making decisions about resource allocation on our own. If one of us is on a triage committee, that's a different story, but our discipline does not address who gets access to what. And a colleague of mine, Amit Arya, just wrote a really nice paper about the roles of palliative care in this pandemic. And it's worth mentioning this quote, any triage system that does not integrate palliative care principles is unethical. Patients who are not expected to survive should not be abandoned, but must receive palliative care as a human right. And to return again to Joan Didion, the concept that the specific forms of grief people are experiencing now are more complex than perhaps they've experienced in the past. And she writes in The Year of Magical Thinking, a single person is missing for you and the whole world is empty. I think now that doesn't just apply to the death of someone we love, but rather the inaccessibility of someone we love because of social distancing and because of the visitor policies. So I think it's worth bearing this concept in mind as we navigate how people are experiencing being sick at this time. Goals of care discussions that we should be doing early and often are especially more important now, particularly in the outpatient setting. In the setting of COVID, we're often making decisions under duress. Families not allowed to come into the hospital, and there's anxiety and fear around the thought that patients may be denied care because of resource allocation. We know that advanced care planning in our country at baseline is not well done. Only about 1/3 of American adults have an advanced directive. And even if they have an advanced directive, it doesn't necessarily mean they've had a really good fleshed out goals of care discussion with their providers or their families. The reason being is that an advanced directive tells us very limited things in general. It tells us who a surrogate decision maker is and who an alternative is. It tells us decisions about organ donation and about code status, but it doesn't get into the finer, more nuanced points about what quality of life someone wants for themselves and what medical interventions they would be willing to go through to try to achieve some semblance of the quality of life they have at baseline. These are more nuanced questions that I think are really best begun in the outpatient setting with providers that patients and families know and trust, particularly now. Because when people are not yet sick enough to be in the hospital and they and their families can talk to someone, to a provider they've known for a long time, those discussions may be fuller and the answers that people can give may be better thought out because they have the time and the space to think of them. And it's not that somebody's peri-intubation and having a goals discussion with providers they've never met before. So I strongly suggest that everyone who sees patients in the outpatient setting try to initiate these discussions, particularly now when we know that COVID can strike unexpectedly and people can get extremely sick very fast. These discussions, particularly around code status, are also newly delicate because there are institutions and states where there are automatic DNR orders placed for patients with COVID. And so approaching those discussions with known and trusted providers, again, I think will make those discussions more meaningful and rich. Of note, our consultation team at Keck and Norris, our palliative team, automatically consults on all patients in the COVID ICU and on patients on the floor who are suspected to need ICU care soon. We do family meetings with the ICU team and the patient's family via Zoom every 2 to 3 days so that we are really trying to keep people updated on their loved one's status and to make sure that we establish continuity with patients and families to help have some of these discussions, particularly if there have been no prior discussions of these issues. I hope that everyone will get a chance to check out Vital Talk's guide on goals of care discussions amidst COVID. I think this slide is one of my favorites because, or this chart's one of my favorites because it's addressing specific things that come up, not just now, but in general, but have a particularly difficult resonance in the setting of COVID. So while I don't have time to get into all of the verbiage on this slide, I do hope that you'll get a copy of the slides and can take a look for yourselves about suggested responses to things like, I want everything done, I want to live. In there, I've added my own verbiage and suggestions about how to deal linguistically with the concept of wanting, quote, everything done. So that's under SP, my initials, and everything else is from Vital Talk. So I hope you get a chance to check this out, and I'm happy to email out the link as well. Palliative medicine for non-ICU patients is also a very important part of really taking care of people in this challenging time. So we should ideally be consulted for all patients triaged to the red and yellow group. And we can really help with symptomatic management such as refractory dyspnea, anxiety, pain, and other issues that might arise from COVID or from other conditions that patients have had at baseline. As mentioned, even in patients not in the ICU, having these ongoing family discussions around care goals via Zoom is so urgently important right now. And we can also assist with coping in this era where families cannot connect normally with their loved ones. Some of the things we've suggested is for families to record audio notes expressing their love and care for their loved one in the hospital. And particularly if that person is intubated and sedated, we can take the audio notes into their room and play it for them. We can suggest playing music that the patient would love or sacred hymns that might be comforting to them. So really engaging with the help of patient experience and our colleagues in the hospital on finding creative ways to connect families during this time. And of course, providing support to our medical colleagues, our medical staff colleagues, and nursing colleagues. The last thing I'll mention is that hospice discharge is somewhat newly complex because there are hospices that won't necessarily accept patients with COVID. This is less the case in California than in other parts of the country, but some hospices, even around here, are a little nervous about taking patients with COVID, so we can sometimes interface helpfully in those situations to try to make sure the patient gets what they need in a safe way. The last thing I'll say is something that Dr. Perrin Cobb from the SICU has been saying a lot on COVID calls, which is this idea, never waste a good pandemic. And what he means by that is that crises really highlight the broken parts of our healthcare system and of our society. So the health inequities that we have been so slow to address in general have become more urgent to address because of what the COVID crisis has shown us. So that's an opportunity for us on a larger scale to rethink how we provide care and how we can benefit people who need that care the most. Palliative medicine has always been a scarce resource, and so I think the increased need for our skill set now really points to how we might be able to improve primary palliative care skills for all physicians and nurses, and as well as increasing access to specialty palliative care needs. Perhaps this is an opportunity to really jump on doing advanced care planning and pulse in the outpatient setting and establishing triggers for inpatient and outpatient palliative consults. I'd like to end just acknowledging the grief, the idea of grief that we're all experiencing at some level because of the turbulence that COVID has brought, and the grief, the complex grief that our patients and families are facing. Grief is tremendous, but love is bigger. You are grieving because you loved truly. The beauty in that is greater than the bitterness of death. Allowing this into your consciousness will not keep you from suffering, but it will help you survive the next day. And this from Cheryl Strayed. And this is Vanilla Ice. Can't catch the coronavirus if you're already the illest. Thank you so much. And I will take questions. And as we're getting to questions, I will also show you my reference slide. There are more references that I used in the development of the ethics policy than are listed here, and I'm very happy to send those to you if you're interested. Thank you so much.